Born and raised in New York State, he received his medical degree from NYU and completed his internal medicine residency at the Albany Medical Center, where he later joined the faculty and became the program director of the medicine residency training program. And then 3 years later, the vice chair for academic affairs in the Department of Medicine. In 2010, as he said, he went through his mid-career crisis. He moved to Denver, Colorado, and accepted the position of chief of academic medicine at St. Joseph Hospital, where he oversees all the graduate medical education programs and the ambulatory clinics. And he also serves as the designated institutional official, or the DIO, for the ACGME accredited programs. Dr. Steinmann's held numerous roles in national organizations, particularly in the Association of Program Directors in Internal Medicine, or APTIM, and the Alliance for Academic Internal Medicine, or AIM, notably as the chair of the Public Policy Committee, the chair of the Advocacy Committee, APTIM president, and member of the AIM Board of Directors, which included 2 years as the vice chair. He's also held numerous positions and received awards in the ACP, including as New York Chapter's Laureate Award, Colorado Chapter's Laureate Award, and currently the governor for the Colorado chapter of the ACP. Today, Dr. Steinmann is going to be leading a session on financing in graduate medical education, a topic that affects each of us in our roles as trainees or as faculty, academicians, and educators here at Robert Wood Johnson. So thank you very much, Dr. Steinmann.
Thanks. Let me get my screen going here. Is that looking good to you guys?
Looks good.
Okay, great. Okay, thanks. Well, thank you for having me. I appreciate the opportunity. Anytime anyone is willing to hear about GME Finance, I'm happy to speak about it. So it can sometimes be a dry topic. I'll hopefully keep it going. I'm not sure I'd be doing my service to Colorado if I didn't show one picture of the mountains here. This is actually, I just took this past Saturday on a hike that my wife and did. That's Silver Dollar Lake down below there. It was really a nice day. As I was saying earlier, the smoke from the California fires has started to clear, so we can actually start seeing some of the mountains. The educational objectives for today's presentation, we're going to talk a little bit about the history of GME Finance. It's kind of a dry topic, and I find that going through the history kind of keeps it a little bit more interesting, but also helps us understand how we got into the mess that we're in now with GME Finance. Talk about some of the limitations of our current systems and what attempts there have been at reform, and then do a little bit of looking at the question of what's the cost of training residents. And there's a few different ways that we'll look at that. The first slide really just kind of sets the tone for what we're talking about as far as the various sources of funding. I don't have a total figure on this because it changes year to year. We're in the neighborhood of about $20 billion of public funding of GME in the United States. And what I want to get across in this is really just the different components of it. And the first thing you see is that more than half is from Medicare. The biggest part is the indirect medical education funding, and we'll talk about that and that as well as the DME. And the DME is the next is the other big Medicare piece, roughly half, a little bit less than half of the IME. And then we have, I'm going to jump over to the purple here. The purple is various state appropriations. And this has multiple different forms, but mostly it's a fee for service through Medicaid, because then the states get a matching amount of dollars from the federal government, which is this green chunk here, which is federal Medicaid. So we're seeing, these really large components of GME. And then you start to get down to the smaller pieces, the VAs, the Department of Defense, Children's Hospital GME, which is a bit of a different animal because it doesn't work through Medicare. It actually gets appropriated by Congress every year, as does money through HRSA. That includes the THC program for HRSA, and then a little bit of NIH. So this is kind of the relative pieces as we're looking at the funding streams. So getting back to our historical perspective, as many things this country did, World War II was one of the defining points. Prior to the 1940s, residency costs were pretty meager. It was kind of a glorified apprentice model in a lot of ways. Hospitals paid for trainees, not medical schools. And these costs were modest, and they were built into their normal customary charges and passed along to payers. Residents are called residents because they used to physically live at the hospital, and room and board mostly constituted their compensation. Often they didn't have any compensation beyond room and board. And then a couple things happened after World War II. One was a lot of folks coming back from the war were able to do residencies and be supported by the GI Bill, which provided a boost in salaries. And kind of as a rising tide lift all boats, salaries in general rose for residents after World War II. The other thing that happened was more formal specialty residencies were established. 3 of our 4 residencies here at St. Joe's in Denver, medicine, surgery, and OBGYN, were all established in the late 40s when these residencies were expanding. And so this started the first kind of big expansion of GME in the country. But the costs were still relatively modest, certainly more than they were before the war, and still passed along to payers. And then the big change came really in 1965, or I should say the first big change from the federal funding perspective, and that's when Medicare was born. In that legislation, Congress actually explicitly acknowledged the need to support GME. But actually, let me get all these up here. And in that statement, it was very interesting because they said that GME should be supported because it increases the quality of care at the hospitals in which it occurs. It was not framed as a general public good. It was really framed as something that improves quality, which is interesting because I don't think at the time they really had any data to support that. Now there's some data to support that, but it was an interesting kind of leap at that time. And they said that the cost should be borne to an appropriate extent by the hospital insurance program, meaning not just Medicare, but all insurance programs. And then they threw in this phrase, until another mechanism is established, which we're still kind of wondering what they were intending there. But it did kind of set a precedent. And essentially at that time, there existed an all-payer system where the costs were still just passed along to the payers. It really wasn't much different. Medicare acknowledged that they would pay their share, but other payers, including individuals who were paying out of pocket, also paid their share because those costs were built into the usual and customary charges of the institutions. And then 20 years later, it starts to get a little bit more complicated. And we start to end up with a system that we're more familiar with now. So 2 pieces of legislation in the mid-'80s really changed the landscape. And this was mostly related to the fact that Medicare was switching to what was called the prospective payment system for reimbursing hospitals. And that was based on what we now know as DRGs. And so instead of kind of paying on a per diem basis, Medicare would reimburse based on the diagnosis and complications. And there wasn't really the charges were fairly uniform. So they needed a different mechanism to recognize and pay for medical education. So the first, actually, it's fascinating to me that IME came around a year or 2 before DME, but the idea of indirect medical expense reimbursement is it recognizes the higher cost of care at teaching hospitals and increases the Medicare reimbursement for services those hospitals provide based on the resident to bed ratio. And when they say increased cost of care, it was never really very well defined. The notion is that just having teaching programs increases your costs. And we're going to get to this toward the end of the talk where we assess this a little bit more formally. But those things like patients hang around longer, residents order more tests, patients are more complicated in ways that aren't captured in other kind of severity of illness mechanisms. And it was really pretty much just that empiric. In fact, initially, they wanted to have a 5.795% add-on to Medicare charges. And they said, that doesn't look right, let's double it. And that's literally how they decided how much the IME reimbursement would be. And we're not going to go into details over the formula, but it is based on the resident to bed ratio. And actually, let's go. So if the IME payment, the current rate is 5.5%, by the way, it's been whittled down over the years. And so the Medicare payment rate is increased by 5.5% for every 0.1 increment in your resident to bed ratio. So a hospital with 1 resident to every 10 beds would receive an additional 5.5%. 2 residents for every 10 beds would receive an additional 11%. And that's for all your Medicare billing. So you see how it gets to be such a large number. It really is a significant revenue stream for teaching hospitals. So it says, ooh, look at that, Schuster. Dogs are so cute when they try to comprehend quantum mechanics. We're the dog here, and this is CMS, and we're trying to understand what's going on with IME. As I said, it gets complicated. DME, fortunately, is a little bit more straightforward. So a couple of years later, when the prospective payment system was rolled out, the DME payments were introduced. And this was based on 1986 Medicare cost reports. Each hospital, through those cost reports, was assigned a specific per resident amount, or what we call a PRA. I'm sorry, it was for fiscal year 1983. And so whatever your costs you incurred in 1983 per resident on your Medicare cost charges is basically what you were tagged with forever. It's been adjusted for inflation with a couple exceptions, but it's largely been adjusted for inflation, and that's it. So, you know, when I think about this, I was a resident I became a resident in 1984, and you know, the program requirements were, I don't know, maybe 5 or 6 pages long. Program requirements now are, you know, 50 pages long. So, you know, there's been a lot more costs incurred, but it's only been adjusted for inflation. And there are 3 factors that go into the DME payment. One is that hospital-specific per resident amount, which varies from hospital pretty widely. The number of FTE at that institution, not necessarily your total number of residents, but the amount of time they spend in qualified activities at your institution. So when you send a resident to another institution, often you can't claim them. So that gets reduced from your FTE number. And then your institution's or Medicare's share of inpatient days at your institution. So if 30% of your business is Medicare and you have 100 residents and then you have a $100,000 PRA, you just multiply those together, and that's how you get your payment. So it's fairly straightforward. So the DME covers pretty much all the costs you would normally associate with residency programs, including what finance people would consider indirects. That's why in IME and DME get kind of confusing, because what a finance person refers to as indirect expenses isn't really what's supposed to be covered in IME. So DME is supposed to cover the resident's salary and fringe, the teaching physician's time, your overhead, your cost for administratively running your program, your share of overhead costs, your share of the electricity, the cleaning service, all that stuff theoretically is rolled up into the DME payment. And as I said, once you establish these numbers, it's simply you multiply these numbers together to get your hospital payment. There is a resource out there, the Graham Center, which lists all the institution's payments. It usually runs, they don't publish those until the Medicare cost reports are fully adjudicated. So it usually runs a couple of years behind, but each institution's PRA is listed, as well as their IME and DME payments. If you do look at this, you'll see that there's primary care PRA and a non-primary care PRA. There were 2 years in the 90s that they didn't adjust certain specialties for inflation, only primary care specialties. So there's it's a slight difference between primary care and non-primary care, but not all that significant. Did we want to, at this point, do we want to see if anybody has any questions before I start moving on? Have there been any comments or?
We don't have any comments just yet.
Okay.
So,
all right.
Yeah, we can keep going for now.
I'll move on. The other thing that happened in the ADU that technically isn't GME, but often kind of is included in GME when we think about the payments, or the disproportionate share payments. Disproportionate share payments are given to hospitals who take care of a large number of and underinsured patients. Again, it's not technically tied to GME, but because GME often happens at institutions that serve an underserved population, it tends to be tended to be a fairly significant part of the financing of teaching hospitals. And then over the years, as I said earlier, the IME started to get whittled down a little bit over the years. The other thing that was instituted in the early 90s that you may hear about is the the concept of initial residency period. So when somebody starts their first year of residency, CMS kind of tags that person with a certain number of years of finance, of support. So if somebody starts an internal medicine residency, they're tagged with 3 years of full support. If they, in year 2, switch to a surgery residency, which is 5 years, so now they've already done 2, they do an additional 5, they'll do a total of 7 years of residency. Only the first 3 years will be paid in full from a DME perspective. After that, the DME gets cut in half. Just the DME, not the IME. And since the DME is roughly a third, you're still getting about 5/6 of the total reimbursement. But this is also true for fellows in internal medicine because it's only your initial residency period. So if you have a person doing a 2-year fellowship, that the DME will be reimbursed at half. But again, it's only the DME, not the IME. The next kind of big change in GME came about with the Balanced Budget Act of 1997. That's where we get what we call the cap now. So what the BBA did was it started the process of further cuts to IME to where we are now at 5.5%. It limited the total number of residents who could be covered by Medicare payments, with a couple of exceptions that we'll go over. And institutions were capped at whatever number of residents they had in 1996. So whatever they claimed in their 1996 Medicare cost reports was the level that they were capped at. There was a couple of small changes a couple of years later with the Balanced Budget Reconciliation Act. It kind of delayed the reduction in the IME, but not for that long. The next change in GME came with the Affordable Care Act, although really as big and expansive as the Affordable Care Act was, it didn't really do a lot for GME. What it did was there were certain payment practices that it codified in law. So it said that Medicare would pay for vacation time for residents, for conference time up to a certain limit. It would not pay for research time except under very, very specific, rules. And that was helpful because it was, although it was, kind of practiced by CMS, the intermediaries that you work with as an institution on your cost reports sometimes would interpret that in various ways. So it's nice to have that codified in law. There were a whole bunch of unused positions that were redistributed through the ACA. That was a one-time redistribution, but it also set the stage for some further redistributions. It established the Teaching Health Centers program, which was funded through HRSA. It's a mechanism through which mostly federally qualified health centers can sponsor programs, mostly in primary care. These are almost all these are family medicine. There's a small number of internal medicine out there. And they usually have an affiliation with a teaching hospital usually. And that's financed through HRSA, and so has to receive congressional approval. It started a reduction in dish payments as well. And that's about it. That's really all the ACA did around GME. I next want to touch on the IOM committee. Most of you are familiar with that. We're starting to get some more recent history here. The IOM committee was formed at the behest of 7 Western senators who were concerned around the way we fund GME, mostly from a perspective of geographic and specialty maldistribution. Having come from New York State, where it's a cottage industry to produce doctors, I think almost 20% of the doctors are trained in New York State. And coming out west, where when I came here, we only had 2 internal medicine programs in the whole state. You kind of start to see that geographic maldistribution. But the Institute of Medicine, it's no longer the Institute of Medicine, but at the time it was. They formed a committee. Don Berwick and Gail Walensky were the chairs of that committee, to kind of do a review of how we fund GME and recommendations for change. Of course, those recommendations require congressional action, which hasn't happened yet. So really none of these recommendations have been acted upon. But the gist of the recommendations was that, or the recommendations specifically, were that Medicare continues to fund GME at present levels for at least 10 years, adjusted for inflation. They did want to create 2 bodies, GME Policy Council and a GME Center, that would look at innovations These would be funded out of existing GME funds, so it would cause some small reduction in overall GME payments. They recommended combining IME and DME into two new funds, operational and transitional. Operation would be the largest component initially, with the transitional funds being more oriented toward outcomes measures. And then over time, they anticipated a movement to more transitional than operational funding. They also wanted to move to more of a national PRA rather than having the wide range of per resident amounts that exist now. And Medicaid would pretty much stay at the state's discretions. The gist of the recommendations really was that the current system is dysfunctional. The monies it pays doesn't really cover what they say it covers. We'll go over that in a bit. And it doesn't really serve the needs of society, either by the types of doctors it produces or where we need the doctors. The system, as they say, has no brain. They wanted to use GME as a lever to influence the healthcare system. And we could have a big debate as to how efficient a lever GME funding would be. I'm not convinced it would be a terribly efficient lever unless we make some really significant changes in the way things are done. And they felt that the GME system should really support the triple aim of quality, population health, and cost control. They wanted to, again, over time, transition from a GME system based on costs, which our current systems are, to one focused on outcomes, or a performance-based GME system, and have more transparency and accountability. Once monies go to institutions, it's kind of a black box where they end up. How much that money actually goes to support the programs, the residents and faculty, et cetera, there's really no tracing or accountability for that money. And if you think about it, theoretically, the IME doesn't even really belong to the programs, it belongs to the hospital. It's theoretically to account for inefficiencies, but we'll take a look at that in a little bit. So that kind of summarizes the Medicare aspect of GME funding, which is over half. There's other sources of GME funding. Most states, but not all, support GME. Again, most do it through Medicaid, through an add-on to the fee-for-service or direct fee-for-service, and that is so that they can take advantage of the federal Medicaid match and get dollars for that. There's obviously the VA and Department of Defense that supports positions as well. I already mentioned HRSA. Some positions are supported by philanthropy and industry, and hospitals now support a lot of positions. So after the cap happened in the late 90s, it's kind of interesting to look. For the first 3 or 4 or 5 years after that, very few GME positions were added. Everybody said, kind of everything was truly frozen. And then institutions, I think, started looking at it and deciding it made some sense to fund some positions on their own. So positions that happened between about 2002 and 2012 were largely funded by hospitals through operational budgets. And then in the early, like the 2010 to 12, when the AAMC was starting to say, hey, we need to, get more medical students in this country. We need to start more medical schools, expand class sizes. A lot of new medical schools, no one was building new university hospitals for the most part. They were partnering with local hospitals. Often those hospitals did not have GME programs, and we'll go through in a minute, they're able to establish new programs and get GME funding. So starting in 2012, you started to see more Medicare supported positions happening as those institutions began starting new residency programs. So now we're in a situation where it's a mix of new positions supported by hospitals and new positions supported by Medicare through establishment of programs at hospitals that have not done GME before. How states do it is highly variable as far as how much they provide and how they provide it. The total across all states is about 20% of all GME. It's about $3 billion. And there's no statutory requirement that Medicaid support GME. So let's get back to that issue of the cap. As I said, this was based on the number of residents that hospitals claimed in 1996. GME naive hospitals who did not report residents in 1996 and have not had residents since then can start new programs and have 5 years to set their new cap. And there was some recent legislation. What would happen if a resident went to a hospital on a rotation that they set up, and Medicare learned about it, they would inadvertently start their clock. So there are a lot of hospitals out there with very low caps, sometimes less than one, and usually a $0 PRA, since they didn't pay the resident, the institution sending the resident did. And those hospitals then locked into that low cap, 0 PRA situation. And there was some recent legislation to change that, but that was a problem for some hospitals. But you can start new programs at GME naive hospitals. You can also have GME affiliation agreements, which allows you to share caps. So we here at St. Joe's, we have a very comprehensive joint operating agreement with National Jewish Health. We combined our clinical enterprises, and they had some cap positions. And so we have a GME affiliation agreement, so we can be over our cap and claim some additional residents under their cap. The only problem is, since they're largely an outpatient facility, they have no IME cap, so it's only DME. So it's not a lot of money, but most institutions you'd partner with also have IME. So fairly easy. The only requirement for the institution, for my institution, is that we have to send one resident for 1 month per year to National Jewish to be able to have their to be able to share their cap. Hopefully, my computer's acting a little funny. Hopefully, it's not showing up on your end. And rural hospitals and occasionally VAs can access new positions as well.
Dr. Steinmann, all we see is the PowerPoint, the title slide, and it's not active.
Oh, it went, okay, sorry. Yeah,
restart the PowerPoint presentation.
My computer just winked out. So let me, what are you guys seeing now?
So we see the slide, what about the cap, but it's not active.
How's that? We good now?
Now we're good.
We're good. Okay. Oh, there's a little delay. That's interesting. Okay. The other thing regarding the cap is that the Consolidated Appropriations Act earlier this year created a small number of new positions, 1,000 new positions, but those were the first official new positions that have been created since the Balanced Budget Act, with the exception of those at GME naive hospitals. As I mentioned, the Consolidated Appropriations Act also allows us to send up to one resident, one FTE, to a GME naive hospital without triggering their cap setting period. So you could have one rotation fully staffed for a year at another institution without triggering their cap, which is always a concern when we're sending folks to places. And it eliminated caps for hospitals with 3 FTE or less that were established after 1996. So this took care of those small cap hospitals that were no longer GME naive. Now they have a no cap, and they are free to start programs if they so wish. So these are two pretty significant changes, really, that really help when we're thinking about, especially in a health system like ours. We have some hospitals that are GME naive that our residents sometimes want to rotate to, and we never would let them, and now they can. So why does everybody pick on IME? As I mentioned earlier, it's a pretty fuzzy and nebulous empiric concept that was never really rigorously determined. There's no accountability for it. It just flows into the institution. MedPAC and RAND over 10 years ago estimated that IME is at least 50% overpaid. It's probably more overpaid than that, actually. It's a lot of money. It's over twice the DME. It's over $6 billion. And the truth is that the inefficiencies that theoretically go into IME probably have diminished over time. And there's, some, it's not a lot, but there's some recent data that suggests that those inefficiencies really may not exist at all. But at the same time, DME costs have gone up significantly since the 1980s. As I said earlier, just the program requirements alone and the requirement and the expense of fulfilling those requirements has skyrocketed since the 1980s due to regulatory demands, increased requirements around supervision, more detailed curricula requiring simulation in your curricula. All these things, and duty hours restrictions, all these things have increased the cost of residency programs. And remember, as I said, except for inflation, DME has not been adjusted since the mid 80s. So this is from an article I published in Annals of Internal Medicine about 10 years ago. And what it basically does, at the time, we were using the assumption or the data from the RAND Corporation, MedPAC, that IME is about 50% overpaid. And, basically, I'll just summarize this in a few words. If you look at the average cost of producing a resident or having a resident, which I'll go over in a sec, and you kind of added it up across the country, the DME didn't really cover, the DME payments didn't cover it. But if you took the DME plus half the IMA, it actually almost exactly at that time would cover those expenses. So what we were really seeing was a cross subsidy, was as IME costs, legitimate IME costs have gone down, DME costs have gone up almost in tandem. So it's kind of a cross subsidy that occurred that, people were just kind of, not paying a whole lot of attention to. So let's talk about what it really costs to train a resident. Look at kind of fully loaded costs versus net costs, and address the question, do residents really add to inpatient costs? This notion that, this whole notion behind IME, what data do we have around it? Okay. So when we think about costs, one way we can think about costs is what are the total, fully loaded costs of training a resident? What is, you look at their salary, their benefits, faculty time, administrative, all those things that go into the DME. What is that number right now? So in that article in 2011, what I did was I looked at the studies that have been done around this to date. There were, the most recent ones were from the early 2000s at the time. There's one that Tom Naska did when he was doing that with an AIM committee. Mark Seidel up at Harvard had one, and Judy Powell's did one up at WAMI at University of Washington, looking at family medicine programs. And, if you look at those studies, there was rough agreement across those studies on the total cost. And what I do is I adjusted those for inflation. There was also an article in 2008 that kind of estimated some of the costs of the duty hours requirements, so I added those in, and came up with about $130,000 a year. Now, what that did not include was changes in program requirements after about 2005, and certainly didn't include the cost of what we used to call the next accreditation system. Now that it's 12 years old, I don't know what we call it, but it used to be called the next accreditation system, which added further costs. And then in 2014, Ron Benary and Rich Robbins, also working with AIM, kind of reproduced the NASCA study and came up with a range of $180,000 to $225,000 per year across a variety of different program sizes. One of the interesting things, including the 2014 studies, was the consistency in trends. So smaller programs tend to cost more per resident than larger programs. That makes sense. Certain costs are fixed, certain costs are step functions. And so, the more residents you have in your program, the lower cost per resident. More outpatient intense programs tend to cost more per resident. So an outpatient intensive internal medicine program or family medicine program would have higher resident costs. Part of that is that they also provide more service on the inpatient side, so that kind of plays into it. And fellowship programs tend to cost less per resident than per trainee than residents do. And that was kind of in a couple of those studies, as well as the Benary and Robbins study. So now we have kind of a range of the fully loaded costs. We're looking at probably somewhere, adjusting for inflation, $180,000 and up per resident. Are those the real costs? Those are what we call fully loaded costs, and they reflect an overall cost to society. From the hospital perspective, though, they do receive some offsetting support from the government, and the residents provide service that has some value. So let's take a look at that question a little bit. So I did an analysis in just in my program here, so it's just an N of 1. But what I was wondering is, what would it cost us if we eliminated our GME programs? And I did this with some trepidation, obviously. If it came out that we would save a ton of money, I might be on the hot seat with the rest of our senior team. But what I did was, it was a fairly straightforward and simple analysis. I did assume that we would provide the same level of charity care that the residency program does now. It's always been a central mission of our hospital. The charity patients would not go away if the residency program went away, so I maintained the same level of charity care. The savings were basically all costs related to the program. Basically firing everybody, including myself, and getting rid of all those costs. Mostly personnel costs. The clinics would stay in operation as they serve the underserved patients. And then the additional costs or losses would be the loss of GME payments, and then replacing necessary services that are currently performed by residents and faculty. And again, situations vary widely across institutions, but this is the data from our institution here. And what we see, I'm going to move my little picture box here. And this is basically the total across our programs. And it's kind of consistent with, this is from 2017. I did this initially in about 2012 or 13, and then redid it in 2017. Our family medicine program would actually result in a small savings by eliminating program. Again, outpatient intense programs tend to be more expensive. General surgery was kind of the biggest cost generator, mostly due to replacement costs, as well as the lost GME income. Now, if I redid this right now, this would probably be a little bit less of a cost, because now, since we went to a level 3 trauma center, we now have 24/7 attendings in-house. So that was a cost that was built into this. So this probably wouldn't be quite as large a cost. Internal medicine, interesting. When I first did this in 2012 or so, we did not have 24/7 attending coverage in the ICU. So that cost was built in. Between 2012 and 2017, we went to 24-hour coverage in the ICU. So this cost is now more modest of eliminating the residency program. It's just under $800,000. And then OBGYN was about $2 million. And then, of course, just limiting my office is pure savings, and the GME Sim Lab, which actually is not just GME Sim, it's Sim for the whole hospital. So I'm not sure we could eliminate the whole thing. But the bottom line was it would cost our institution about $4.2 million to get rid of the residency programs and maintain the same level of charity care. I did the same analysis eliminating all the charity care, and it was still a cost, although it was much more modest. It was, I think, under $200,000 cost if we also eliminated all the charity care, which probably would not happen. So certainly from a replacement cost perspective and loss of GME, it would be an expense to the institution to eliminate the residency programs. Another analysis that I do every year is if just looking at our budgetary performance across all our clinics, how do we do from a budgetary perspective? And so, we take our total revenue, then our operating expenses, and we come up with an income from operations, and our DME dollars are included right in our budget report. So our program directors get a report, in their financial report is the DME payments. And then the IME, I do get the Medicare cost reports every year from our finance folks, so that we don't know until about 6 months after the year ends. But then we do get some money from Colorado Medicaid. So the net income from operations across our GME enterprise, so to speak, is usually in the neighborhood of a loss of $4 to $5 million. We're not going to look at 2020. 2020 was a mess for everything. So just we'll ignore 2020. that's interesting because the cost of eliminating the program, if you remember, was about 4.2. So kind of thinking in these kind of grand terms, so to speak, GME is kind of a wash for us. We kind of pay for ourselves through the service that we provide to the hospital. In reality, up until 2020, we would also receive about $4 million a year from Kaiser. Kaiser is our largest clinical partner here. About 50% of our inpatient business is from Kaiser. They hire a lot of our residents, so they would provide us about $4 million a year for a GME. So we actually were running much closer to a kind of break even. But when we look at the service that's provided, it really is close to break even for us. And the last question, really, we're going to answer or address here is, what about that issue of efficiency of residents? Is there really a substantial IME cost? There's a very small but growing body of knowledge around this. Folks that have looked at this question, mostly around the question of length of stay and direct costs per patient. The two studies I highlighted here are fairly recent. One from up in upstate in Syracuse. Steve Knoll is the program director up there. And Stephen and I have kind of done a couple of presentations at AIM and ACGME on our kind of analyses. Stephen did a pretty comprehensive analysis of their program. They had almost kind of a natural experiment. They had some teams that were staffed by residents, some teams that were staffed by APPs, and the same attendings worked on both teams. So the attending coverage was not a variable. And what they did when they assessed direct costs and length of stay is they found that their resident inpatient services saved $617 per patient, which accounted for $5.1 million a year, and reduced length of stay by 1.26 days per patient, which accounted for an additional $11.1 million per year. So in their institution, at least, again, these are specific institutions, their resident services were much more efficient than their APP services and saved a considerable amount of money. Jose Perez down at Houston Methodist did a similar, slightly different, but similar study, again, comparing teaching to non-teaching services. Both had hospitalists plus APPs. And similarly noticed lower direct costs in his situation of about $474 per patient, and a shorter length of stay, although not as significant as in the study at Upstate of 0.5 days per patient. But even, as we're monitoring length of stays, 0.5 days is pretty impressive. We would love to have a 0.5 day reduction in our length of stay. And there were some earlier studies that weren't quite as comprehensive, and they showed a more modest to a neutral impact of GME programs and hospital costs. These two actually showed a positive impact. So, this whole notion of IME really comes into question. And, it does really seem to make sense to combine IME and DME into a payment that really better recognizes the full and true costs of training residents. So, I think that there's going to be more data coming out about this as more people look at this question. But these are two relatively recent studies that really kind of bring this into a little bit more focus about in the current day and age, in the current state of medicine, what does the efficiency of residency programs look like? And I think with that, I'll take some questions. I do have one more picture of the mountains here before we kind of go back to questions. Anything I can answer for folks, or any other topics that you'd like to touch upon?
Yeah, thank you, Dr. Steinmann. That was fantastic. It was great. It was a little more than 101. I think it was 101 and 201 and 301, but it was great. I had a quick question while the comments, questions, and chats are coming in about that Perez article that you just showed from Academic Medicine in 2018 that showed the lower direct costs and the shorter length of stay in the resident teams as opposed to the non-resident teams. Were the hospitalists that were in the non-resident teams the same hospitalists that were in the resident teams? So for example, were they more than just comparing resident versus non-resident teams? Were they also taking into account that these were teaching hospitalists versus non-teaching hospitalists?
I know that's true in the study from Syracuse, the earlier one. I don't know if that, I don't think that was expressly stated. So I'm assuming that there are different teams. I don't know if that assumption is correct, but I'm assuming the attendings were different.
Okay. Because, you talk about the financial costs of closing the programs, and it doesn't take into account a lot of secondary effects. So like you mentioned,
Absolutely.
the Kaiser grant, and you lose a lot of clinicians and researchers come to academic medical centers so they can work with trainees. And so,
Yes.
that study, it might be the residents are improving the care, or it might be the hospitalists that are there because they get to work with residents are improving the care. Either way, they're lost if you lose the trainees, not to mention all of the research money that comes in if people don't have residents and fellows to work with, if they're not there anymore.
Yeah, that was not included in my analysis. And like I said, the one thing that was nice about the upstate study is it was the same attendance, just working sometimes at residents, sometimes with. Now, what I don't know is there a differential proportion at a time? In other words, they have some attendings that work more with residents and less with APPs, vice versa. But they did state that it was the same group of attendings.
Great, thanks. So we have a couple questions. Manish, did you want to go ahead and ask your question?
Actually, it's Nell. The question that I have is about the novel programs that have been developed, and these naive programs seem to me to be ways for health systems to get a lot more money, and because of the issue with the caps, also change their caps to suit kind of the needs, I guess, of the overall system. What I'm concerned about is that the feeling that I have, and I don't have any data about it, is that this is a way for systems to play with money and not necessarily quality education. And I was wondering how organizations, like the governmental organizations, are looking at these new programs in terms of quality, since there is such a benefit to starting a program in a naive hospital.
Yeah, no, that's a great observation. I think there are. I don't want to be too accusatory here. There are some health systems that really do look at GME as a business opportunity. One thing, as I said, they can use affiliation agreements and close programs for really large systems. They can close certain programs and consolidate them at another hospital. So, some health systems that are very large, kind of do that. And then the GME naive hospitals, they certainly could open a new hospital and then redistribute those positions after 5 years elsewhere. You could do that through affiliation agreements. But most of the time, I will say that even for-profit health systems understand that there is value to GME. They use it. They actively recruit those folks, so they save a ton of recruitment costs. There are service implications of it. So they have done the math, and I think they kind of understand what we were saying toward the end of the talk there. There is an ROI on GME, particularly if you're a large health system that can, hire a good number of these physicians as they exit training. But there's one particular for-profit system in the country that's very aggressive around GME.
I think what I'm asking is, like, how do you evaluate the quality in these? There's probably again in New Jersey, there's probably been about 4 new surgery programs that have popped up in the last couple of years. And, sort of as you were saying about the imbalance of where trainees are coming from and going to, how do you account for that? Like there can't, it seems again like that in these newer programs, there has to be some difference in quality overall based on who's getting recruited into them and otherwise, and who monitors that. I agree that there's value. I mean, I think that that's exactly the point, is that I think there's great value to the institutions to develop the new GME programming.
I mean, that highlights the basic problem that the IOM was asked to address, right? There is no central brain in GME. The Medicare leaves the quality issue up to the ACGME. So as long as a program meets ACGME requirements, Medicare is going to make the payments. They're not concerned so much with what specialty or where it is, as long as it's ACGME approved and you meet the Medicare qualifications, they're going to pay. There is no monitoring of from that perspective on the CMS side. And that's why we say the system really it has no brain. There's rules set up, and you follow rules, you get paid.
There's a thank you. We have a question from one of our very insightful residents. Wanted to ask, what can we do to increase the transparency and accountability of the money coming in for our training?
That's a really good question. You can advocate for change, as we've all been doing for many years. Right now there's no statutory requirements around transparency. That again was one of the recommendations of the IOM report that really hasn't gone anywhere. And I will say that accountability varies by institution. Some are much more transparent around where the dollars come from. Others are very protective of that information. The Medicare cost reports, interestingly, are public accessible documents. That's the Graham Center just accesses the Medicare cost reports for each institution and comes up with their assessment. So you can find out how much your institution gets. You don't necessarily know where it goes to, where it comes from. As I said, I was pretty happy here. The DME is right in the monthly budget reports that all our programs get. And the IME, you don't know really what you get in IME until the end of the year. But our finance folks, send me the cost report every year, and I have the whole cost report that I can go through and take a look. It's really pretty easy to find the total IME payment. I think that the short answer is there's no requirement around transparency now, and that's something that's needed in GME. And advocacy is a whole nother thing, a whole nother topic to talk about. I used to do some talks about advocacy, but advocating for change is about the best you can do right now, both within your institution and political change.
Great, thanks. You mentioned earlier about COVID that 2020 was a whole different year. As all of our trainees know, trainees across the country worked harder than they've ever worked before, put themselves at risk that they've never been at risk before, both themselves and loved ones. And there was a lot of desire, both from the trainees and from the institutions, to compensate them somehow, and compensate them by more than just saying thank you. But at the same time, these institutions were losing, millions of dollars themselves. There was no central way to compensate these individuals. Now, there was compensation given to the hospitals, but it wasn't necessarily directed towards the individuals. We can't go back and change what wasn't there in 2019 or 2018. Is there something we can do in the future to centrally help our trainees in the future who are forced to be in circumstances the way they were in 2020 with COVID?
Well, that's a good question. I don't know if I have an answer for that. Certainly, that really is up to the individual hospital and institution. There's probably not going to be a separate funding stream for Medicare to supplement resident salaries, or resident, I shouldn't say salaries, but supplement the monies that flow into the hospitals from that. As you know, the CARES Act money kind of came in big batches, not tied to anything in particular, but just to kind of address your bottom line. So hopefully the institution would look at residents as one component of their bottom line. And if, CARES Act money, came in, hopefully, there would be some recognition of that. And I know that there was a lot of discussion on the Aptum discussion board around various types of supplemental pay for residents that some institutions did and others didn't. But it really gets down to the institutional level of what your resolve is around that.
Yeah, I think one of the problems we see are, hospitals, there was different money given to hospitals than there was to medical schools. And, a lot of times, like you mentioned earlier on in the talk, that a lot of times those two are intertwined. Either one or very closely intertwined, the medical school and the hospital, and sometimes they're not.
Yes, absolutely. And the reimbursements go to hospitals. The GME dollars go to hospitals.
And the trainees are often, but not always, employees of the medical school and not the hospital.
Yeah, that works different ways in different institutions, but you're right. Yep.
Okay, I think we have time for another couple of questions. If anybody wants to unmute themselves or post anything in the chat.
This is Gabby Ferrer. I'm a hospitalist in the Department of Medicine. Has the proportion of the total overall income for hospitals, has that proportion increased in terms of the federal payments? Has that increased as a proportion of their whole income over the last 20 years, let's say?
So you mean
they're
GME
relying more on GME, DME money in terms of their operating budgets than they were 20 years ago.
Okay. Actually, as I kind of mentioned during the talk, a lot of the expansion, especially in the 2000s, between 2002 and 2012, was funded by hospitals. So as a percentage of GME monies, actually the Medicare probably went down, although the absolute dollars went up. As hospitals started funding more positions, the percentage probably went down a bit. It's still the vast majority, but hospital operations dollars accounts for more GME support now than it did, certainly 20 years ago. I don't know percentages though.
Thanks, Gabby. Dr. Steinmann, maybe we have time for one last question. How many, and maybe you know this either from your role in AIM or Aptum or ACP, how many hospitals gave hazard pay to residents in the time of COVID last year? And this isn't part of the question, but I'm curious how that also was broken up. If anybody looked at that, how that was broken up geographically, or in terms of finance, whether the finances came, through hospital or through the medical school.
Yeah, I do not know that. I haven't seen any report on that or study on that. It was pretty, just judging by the chat on the discussion board, it was pretty variable. A lot of places, especially the places that were really hard hit, tried to do something. But as you mentioned, at least in the middle of the fray, with the CARES Act, money not necessarily coming in that fast, finances were pretty uncertain. A lot of places also tried to avoid the term hazard pay and came up with other kind of terms for it, whether it came out to the same thing or not. The idea of hazard pay is not always optimal. I can share our experience here. The first surge in the spring here, while it was kind of significant numbers, as everything else stopped. We stopped elective surgeries. So, the hospital really wasn't super busy, even though we had, a number of COVID patients around. And a lot of our residents, we were just telling them, we programs developed some work at home to do. We were doing telemedicine. So we mostly, try to keep residents healthy in case we had a lot of illness, which we never had. The second surge I call it the second surge, I guess technically it's the third, that we had in November, December, January last year, was much worse from a patient care perspective because we had everything else going on. We didn't stop elective surgeries. The hospital was really busy. Plus we had a large amount of COVID patients. And then we did end up pulling residents off electives and having residents do extra time in ICU. And so we did create a system where we would reimburse folks who had to come off electives, or folks that did, some weekend extra shifts. We would pay them a moonlighting rate for that. So I think there were so many different mechanisms across the country for doing this, but what I don't know is what percentage provided something versus nothing.
Wonderful. Well, that was, we're a couple minutes after the hour. It was really a great talk. Thank you so much. I appreciate it. So thank you, Dr. Steinmann. Thanks you everybody for being here. And next week we'll have Dr. Scott Ratson from City University of New York talking about COVID vaccine hesitancy. And thanks again, Dr. Steinmann.
Thank you.
Thanks, Al. Thank you.
Appreciate it.